Ann Romney, wife of the U.S. Senator and former Republican Party presidential candidate Mitt Romney, developed worrying neurological symptoms. She wrote that the symptoms of my disease didn't appear suddenly and overwhelm me. I wasn't attacked. There was no horrendous pain. The initial signs were subtle and easily dismissed. She recalled that I began feeling a strange sensation in my leg and that from time to time I'd lose my balance or trip going up a staircase that she had climbed thousands of times. She added that the middle part of my right leg was numb and that feeling seemed to be expanding upward into my torso. But the worst symptom for me, she explained, was fatigue, complete and continuous exhaustion. Suddenly, I could barely get out of bed in the morning. She illustrated the disabling impact of the fatigue when she said, "The thought of getting in the car and driving into the city to meet Mitt was just overwhelming. I started skipping meetings." Ann Romney was eventually diagnosed with multiple sclerosis, and she chronicled her illness in her book titled In This Together. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast titled Stripped, Exploring the Enigma of Multiple Sclerosis. In this episode, we will be delving into this notorious inflammatory scourge of the nervous system, and we'll start with Romney's touching account. Ann Romney wrote that, like most people, I knew little about MS except that it was a very serious progressive disease and that after a long period of suffering it could be fatal. Worse still, her neurologist at the time told her that if she got worse, there was no treatment apart from steroids. This, she said, made her feel my life as I had been living it was over. I was devastated, totally devastated. Ann Romney was unfortunately following in the footsteps of an illness with a long reach back in history. Romney's despair over the disease must have been what Lidwina, the patron saint of figure skaters, must have felt when she developed similar symptoms way back in the 12th century. Lidwina is considered by some to be the first person documented to suffer from multiple sclerosis. Narrating Lidwina's story in his book titled Multiple Sclerosis, The History of a Disease, Thomas Jock Murray wrote that Lidwina was born in 1380 in Schiedam, Holland. She was well until the age of 15 years when she developed an acute illness which gradually improved over a year. Feeling better, Lidwina went skating with her friends on a frozen canal where she fell, breaking some of her ribs. Her recovery from this was very slow, and during the course of her recuperation, she experienced difficulty walking and endured violent lancinating pain in her teeth. Lidwina subsequently lost her vision in one eye, and she developed light sensitivity in the other. Again, she recovered from these episodes over the following 2 years. But she continued to accumulate deficits such that by the age of 19 years, Murray said her right arm became paralyzed and she developed a split face and hanging lip. By then, he said, she could walk only with difficulty. From then on, Lidwina's clinical course was pockmarked by episodes of loss of sensation, pain, sores, difficulty swallowing, and loss of mobility. But between these episodes, Murray pointed out that she had occasional periods of improvement. Along with her physical symptoms, Lidwina also experienced what were interpreted as spiritual manifestations. According to Murray, beginning in 1407, she experienced ecstasies and visions in which she participated in the Passion of Christ, saw purgatory and heaven, and visited with saints. He added that her parish priest, Father John Pott, visited regularly and suggested that she join her suffering with that of the Lord. Murray said that Some 3 years later, she realized that she was called to be a victim for the sins of others. This no doubt contributed to her elevation to the station of patron saint of figure skaters. Lidwina's condition went on for 37 years until she died in 1433. To add to the mythology that was growing around her, Mary said people reported that her putrefying body gave off a fragrant perfume. Citing many experts, Mary concluded that Lidwina fulfilled the diagnostic criteria for multiple sclerosis. The modern understanding of MS can be traced to the great pioneering clinical neurologist Jean Martin Charcot. Charcot first became aware of the disorder in 1855 when he observed a woman who had some problems with her movements, and he thought these might be caused by neurosyphilis. Ever curious and keen, he set out to study her at closer quarters. And to do that, he hired her as his housemaid, and during her employment, she broke many dishes due to clumsiness of her hands. Charcot was able to follow the course of her illness over the years, indeed at very close quarters. When it became clear that she could no longer work, Charcot admitted her to his hospital, the Petit-Salpêtrière Hospital in Paris, where she eventually died and had a post-mortem examination. True to type, Charcot studied the pathology of her nervous system and found grey patches or plaques in her brain and spinal cord. Charcot went on to examine and present further similar cases of the disease that he eventually named, pardon my French here, sclerose en plaques disséminées. In his illness story titled The Unmapped Mind, Christian Donlan accurately described MS as a disease in which the body's own immune system decides to attack the fatty, insulating coating of the nerves in the brain and spinal cord. He went on to explain that this coating, made of a substance called myelin, protects our nerves and speeds up those vital electrical pulses moving from one neuron to the next. He added that without myelin, crucial signals between the brain and the body become garbled or simply go missing entirely. The relapsing and remitting course of multiple sclerosis and the diversity of symptoms which typically accompany the disease ensures that the diagnosis is a challenging one to make. This difficulty is graphically illustrated by the story of writer and teacher Meredith O'Brien, as she chronicled in her book titled Uncomfortably Numb. O'Brien's illness began when she was 43 with what she said was something weird going on in her left leg. She couldn't feel the blade on her skin when she shaved her legs, and over a few days the numbness spread down to her left foot and up to the thigh. O'Brien saw a neurologist who ordered an MRI scan of the brain and spine, and he did this with the injection of contrast or a dye. The MRI showed that she had a 10-millimeter lesion in her upper cervical spine in the neck. Her neurologist, however, did not think this was sufficient or significant enough to constitute MS. Rather, the dismissive neurologist said the cause of her presentation was unlikely to be this lesion, and he attributed her symptoms to anxiety. A year later, O'Brien said she developed new areas of numbness, including on the back of my left hand, across my fingers, and on my wrist. And all this while, her leg numbness was dissipating. A repeat MRI scan at this time showed nothing new, and her neurologist wondered if her symptoms were psychosomatic, or, he gave her the benefit of the doubt, maybe small fiber neuropathy, damage to the small nerve fibers. It was not until O'Brien started grappling with a never-ending sense of fatigue weighing me down like a heavy blanket that she decided to seek the opinion of an MS neurology specialist. By this time, her left leg numbness had spread to her chest, and she was experiencing tingling and heat sensations, as well as spasms and jerks in her leg at night. This was when she was eventually diagnosed with multiple sclerosis. A lesson here for neurologists is always follow up inexplicable symptoms rather than explain them away. With hindsight, O'Brien realized that she had been having MS symptoms as far back as the age of 24 years when, as a newlywed bride, she experienced a 1-week episode of numbness in the left arm, and half of her face felt like Novocaine wearing off. And at the age of 28 years, whilst undergoing fertility treatment, she felt the right side of her face freeze and become impassive. She was unable to smile with that side of her face. That episode was, again, misdiagnosed as Bell's palsy. Other symptoms O'Brien experienced over the course of her illness were migraine-like headaches, altered taste, cognitive slowing, and MS hug. This is a tight sensation that goes all around the trunk. She also experienced Ohthoff's phenomenon, which is impaired vision in hot environments, and Lemitz's sign, an electric-like sensation that runs down the spine when the neck is bent forward. She has done her research. O'Brien was appropriately diagnosed with the relapsing remitting form of MS. Although her story goes to show the diversity of symptoms of MS, neurologists have over time attempted to confine the features to what they think are most suggestive of the disease. These endeavors to tame the symptoms of MS go back to Jean Martin Charcot, who argued that the triad of intention tremor, nystagmus, which is rapid eye movements, and scanning speech constitute the defining features of multiple sclerosis. Since then, many other symptoms have been fingered or flagged up as red flags for MS. Amongst the most important are optic neuritis, or inflammation of the nerve for vision, transverse myelitis, which is inflammation across the spinal cord, and trigeminal neuralgia, that dreadful shooting pain that can occur on one side of the face. But the list of MS symptoms is so varied that this narrow view simply increases the risk of not making the diagnosis or not making it early enough. It is therefore important, as we have seen so far with Romney, Lidwina, and O'Brien, to keep an open mind that MS can manifest with any symptom. Many of these symptoms are unusual neurological manifestations such as impaired smell and taste, sleep disorders, cognitive impairment, abnormal movements, depression, and even psychosis. And others are systemic symptoms that involve other organs such as constipation, incontinence, and erectile dysfunction. Relapsing remitting MS, which O'Brien was diagnosed with, is the major form of the disease. A sinister fallout of this form of MS, however, is when it transforms into what is called the secondary progressive form of MS. This often develops years after and is characterized by symptoms which, instead of resolving, gradually progress, obviously. A more worrying form of MS is when it starts off right from the start as progressive MS. This so-called primary progressive MS does not manifest with relapses and remissions of symptoms. Rather, it expresses itself as a steady accumulation and progression of symptoms over time. The presentation of primary progressive MS is vividly portrayed by musician John Laverton, who accurately depicted this in his memoir titled In the Game. Laverton wrote that the first hint that a strange malady had appeared in my life was in 1994, when one day, while trying to jog, it was as if I was running in mud. He subsequently noticed that his right foot was starting to drag a little after 30 minutes of walking. This interval gradually reduced over time, eventually requiring him to stop and rest after walking for just 10 minutes. Over time, he developed impaired balance, and this happened especially when he walked on cobblestones. and if he stood in one place for a long time, his legs and his lower back would stiffen up. Unfortunately, Laverton's symptoms also affected his music. He described how he developed problems playing high notes on the trumpet. He also had difficulty standing for long during rehearsals or when performing, and difficulty getting off the podium after conducting. To overcome his walking difficulty, he resorted to using a cane. But with time, he progressed to using a walker, saying the added mobility was well worth the hit to my pride. The devastating progression of primary progressive MS was also captured by Jen Pauli in her illness memoir titled Just Jen. Pauli narrated how her MS crept in surreptitiously, starting with a tendency to run on her toes and then trouble with her balance. As her illness progressed, Pauli remarked that with multiple sclerosis, I am constantly saying goodbye to my abilities and unlearning the skills I once mastered. She wrote of difficulties doing zips and buttons, of using cutlery, and of putting on mascara. She also developed urinary difficulties when she said, "The sphincter on my urethra stopped my commands. I would sit down to pee and nothing would come." Sadly, she had to resort to self-catheterization, diapers, and eventually a suprapubic catheter. Beyond the three major types of MS we have come across so far, there's also a list of MS variants which include the Marburg variant, Baylo's concentric sclerosis, and tumefactive MS, way beyond the scope of this podcast. So perhaps this is the right time to take a step back and ask the elephant in the room question. What is the cause of multiple sclerosis? Although our understanding of MS has advanced significantly since the days of Charcot, the cause of MS continues to elude us. And the short answer to the question is we do not know what causes MS. But there are various risk factors for the development of MS. Let us explore this with the story of physician Lisa Doggett, as she narrated in her illness memoir titled Up the Down Escalator. Doggett's illness began with what she called a constant and steady dizziness, which she described as an unpleasant buzz combined with something akin to jet lag. This was followed a few days later by double and then blurred vision. After an MRI scan, which revealed some white matter changes and a spinal tap, she was diagnosed with multiple sclerosis. Very early on, she asked, was I really just diagnosed with MS? And how can this be happening? I was healthy. I had always been healthy. My medical history was boring. The worst disease I've ever had in my whole life was mono. After she suffered relapses, she said, I couldn't stop asking the ultimate question, the one that plagues many of us with serious medical problems. Why me? Why did I get MS? On reflection of what she learned about the risk factors of MS, Doggett said, I did have a couple of strikes against me. MS is 2 to 3 times more common in women, and while it can occur at any age, most often it affects people 20 to 50 years old. She also wrote that Epstein-Barr virus, the cause of infectious mononucleosis, or mono as she called it earlier, was being investigated as a potential trigger for MS, with mounting evidence of a link. For this reason, she said, I wondered if having mono in high school could have caused MS to develop nearly 20 years later. She, however, argued to herself that I lacked other risk factors, smoking, family history, other autoimmune diseases, living in the northern part of the country. She therefore asked herself, surely I wasn't always destined to have MS? Even if Epstein-Barr virus could trigger MS, why did it happen to me? Most people who get EBV are fine. So what was the inciting event, the very first thing that caused my immune system to attack my central nervous system? She therefore carried on her search for answers, asking, was it because I was a vegetarian, as the acupuncturist had implied some months earlier? Was it from some toxic exposure during our home remodel or some other environmental pollutant? Had I become vitamin D deficient by spending so much of my young adulthood indoors training to be a doctor? Was it from stress, sleep deprivation, soy, or gluten? Maybe I picked up a parasite on a trip to the Amazon during residency. Maybe I got some weird infection from accidentally eating spoiled food. Or could it even be from not drinking alcohol? Was I too much of a goody two-shoes? Doggett is indeed spot on concerning the way risk factors congregate to lead to multiple sclerosis. Some of these risks are non-modifiable, such as Caucasian ethnicity, a strong family history of MS, an earlier age of menarche, migrating to high MS incidence areas before adolescence, being born away from the equator, and being born especially in the month of May in the Northern Hemisphere and in November in the Southern Hemisphere. But more relevant, because of the potential they offer for intervention, are the modifiable risk factors of MS. And the current top dog, as highlighted by Doggett, is indeed infection with Epstein-Barr virus, the cause of mono. Other modifiable risk factors include low vitamin D, smoking, childhood and adolescent obesity, and head injury. A lot there we can help to prevent. But even when one understands how different risk factors can contribute to MS, Doggett's case shows that the why me question lingers for the patient. But for the jobbing neurologist, the initial concern is to distinguish MS from its many mimics. In this regard, neuromyelitis optica, called NMO, leads a pack that includes legion of inflammatory and autoimmune diseases, neurological infections and tumors, as well as a host of metabolic, vascular, and drug-induced disorders. To tease this out and be certain that the diagnosis is multiple sclerosis, the neurologist resorts to a variety of investigations and tools. As we have seen so far, the main investigation is an MRI scan of the brain and spine. A neurologist will want to have a look at the whole spine. The MRI in MS usually shows lesions with a characteristic appearance and distribution which help to distinguish it from its mimics. And an MRI scan taken after the injection of a dye or contrast also helps to tell whether an MS lesion is new or active, or if it is old. An MRI is typically followed by analysis of the spinal fluid obtained through a lumbar puncture or spinal tap. Neurologists mainly request a spinal tap to look for the presence of oligoclonal bands. These are proteins which non-specifically indicate inflammation in the nervous system, but this inflammation is often considered highly suggestive of MS. An excess of cells and protein in the spinal fluid may also help to point to other diagnoses rather than MS. The third set of tests done in the workup of MS are neurophysiological, and the main one is called visual evoked potentials. I would not go any further regarding this, but there are other evoked potentials done in MS which include brainstem evoked and somatosensory evoked potentials. Other investigations the neurologist will often request include a raft of blood tests, and these are too many to explore in this podcast. After all the tests are done and dusted and a diagnosis of MS is established, comes the heavy lifting of the treatment of MS. Unlike Romney's days, there are a lot of options now. The initial treatment for almost all people presenting with an MS episode or relapse are steroids, and this is illustrated in Meredith O'Brien's case. Steroids are short-acting inflammatory treatments which may shorten the duration of an MS episode but doesn't alter the final outcome. O'Brien was also put on Tecfidera, one among the increasingly expanding list of MS disease-modifying agents which reduce the risk of MS relapses and which have revolutionized the treatment of the disease. The list of MS disease-modifying agents is, however, increasing at an exponential rate. Amongst these are the old-timers called interferons, the monoclonal antibodies such as natalizumab, alemtuzumab, ocrelizumab, and rituximab, yes, the MABs, the oral agents dimethyl fumarate, fingolimod, and cladribine, and the newer agents siponimod, ozanimod, and ofatumumab. Besides the disease-modifying treatments of MS is a host of symptomatic and general treatments. For example, John Laverton received vitamin D supplementation, physical therapy, massage therapy, and exercise. Other treatments in this category include the use of amantadine and modafinil for fatigue, oxybutynin and tolterodine for urinary symptoms, baclofen and tizanidine for spasticity, and amitriptyline and citalopram for emotional lability. This list is, of course, by no means exhaustive. To explore the cause and management of MS further, I will be speaking to top neurologist and MS specialist Stephen Hauser, author of the book titled The Face Laughs While the Brain Cries. And this will be in the next episode of this podcast. Thank you so much for listening to or watching this podcast, in which we started our exploration of multiple sclerosis. If you found it enlightening, you might consider subscribing to the Neuro Checklist website, where there's a lot of information about MS. And you might also want to explore my book titled Surfing the Brain, which is a light touch neurology. And to make sure you do not miss the next episode, why not subscribe to the iTunes, to the YouTube, or to the Spotify channels of this podcast. Do join me next time when I speak to Stephen Hauser. Thank you very much and have a good time.